Okay, when we talk about pediatric assessment, remember that as a general rule, PEDS assessment is a little more challenging than it is assessing adults, because the younger a child is, the less ability they have to effectively communicate and to be able to describe symptoms and problems that they're experiencing. So in PEDS, we actually focus our assessment on three things when we're trying to figure out just a really quick assessment of whether this kid is sick or not sick. And that's what it boils down to in PEDS. When you walk into a room and you're going to take care of a PEDS patient, the big thing you want to know right off the bat is this kid really sick or not so sick? And we can make a lot of that judgment based on looking at three different things. So the first thing we look at is the level of consciousness. And remember, when we talk about level of consciousness in PEDS patients, we always want to consider what is their level of consciousness compared to their age. Are they acting appropriate for their age? So, for instance, things that may not be such obvious changes in level of consciousness, but are definitely suggestors of a change in level of consciousness, would be things like the preschooler or the toddler who doesn't have stranger anxiety. That's abnormal. We expect that, say, a 2-year-old is not going to know who you are, has no interest in knowing who you are, and doesn't want anything to do with you. When you walk into a room and you have a 2-year-old who doesn't seem to really care about the fact that you're touching them and invading their space, that's abnormal. We would not expect that in a 2-year-old. Now, other things would be things like if you're taking care of an infant and the mom says something like, well, ever since she's been sick, all she does is sleep all the time. Well, that can be a sign of a change of a level of consciousness. So that's the first kind of pillar, if you will, to assessment of kids. What is their level of consciousness in relation to how we would expect them to act at the age that they're at? The second thing that we also want to think about is what is their perfusion status? And a lot of times in kids, assuming that they're in a warm environment, assuming that they're not out in the cold, we can actually get a lot of information about their perfusion status just from their capillary refill. A lot of times pushing on their skin will give us a really good idea of how well their perfusion is. We want to think about what's their color, we want to think about what's their capillary refill, what do their distal pulses feel like, all that good stuff. And remember that in kids, when they get in trouble, one of the very first things they typically tend to do is they tend to start shunting blood towards their core, just like adults do. So when kids have a decrease in their perfusion status, we're going to see that manifested as things like lengthening of the capillary refill, weakening of distal pulses, or we may see that as like modeling of their distal extremities and things like that. Finally, the third thing that we want to look at is what is their work of breathing. Remember what we said about kids. We said that they're almost working at an oxygen deficit all the time. Almost an oxygen deficit. So they're always chucking along, breathing and breathing and breathing and breathing. Well, anytime that they get in trouble, all they're going to do is increase their respiratory pattern as much as they can until they fatigue and they can't anymore. So one of the things that we see when they increase their respiratory drive is they do things that demonstrate respiratory distress. Things like they get retractions, we may see the seesaw breathing, those types of things. So when kids are in trouble, their work of breathing goes up, and when their work of breathing goes up, they really tend to involve extra musculature and start to use those accessory muscles a whole bunch. Now, remember that they'll do that as long as they can, but when they fatigue, they fatigue. And when they fatigue, then what we see is the exact opposite. We see that they start to slow their breathing down. We see that they start to slow their workload or decrease the workload, decrease the muscular activity. And remember again, in PEDS patients, just like with the heart rate, respiration is the same way. We expect when kids are in trouble that they're going to get tachypnic and that they're going to really, really work hard to breathe. When we've got a kid who's obviously in trouble and they're not doing that, they're not working hard to breathe, then that proves to you that the kid is in respiratory failure and that intervention is necessary. Okay, when we talk about PEDS resuscitation, just a couple of generalizations here. I'm not going to waste your time reviewing PALS with you because I know that you guys have all had PALS before. But remember, with resuscitation, the big thing is airway management is everything. Remember that typically when kids go into cardiac arrest, it's because of a precluded respiratory arrest or because of shock. So when we talk about resuscitation, obviously those are the two big things we're going to focus on. We want to make sure that they don't go into respiratory distress. We want to make sure they don't go into shock. And the way we make sure that they don't go into respiratory distress is we supplement oxygenation and ventilation anywhere from just providing supplemental oxygen up to actual intubation if we need to. Remember that airway is paramount. Everything revolves around the airway in peds patients, actually just like it does in adults. When we talk about ET tube size, there's two different formulas out there, whichever one is easier for you to remember. One of them is age divided by 4 plus 4. The other way to calculate the ET tube size, the one that we've already talked about other places, is age plus 16 divided by 4. When we talk about depth of insertion, there's also two different formulas out there. One of the formulas is age divided by 2 plus 12. The other formula is 3 times the ET tube internal diameter. Again, whichever one is easier for you to remember. When we talk about IV access in critically ill kids, remember that the thing that's kind of been taught for years in PALS is if you have a critically ill kid, you need IV access. Typically, we shouldn't spend any more than about 90 seconds or 3 attempts trying to get IV access before we transition to an IO. Remember that when we talk about IOs, we can push everything through an IO that we can push through our IV, including blood products, vasopressors, all that good stuff. When we talk about cardioversion, remember that the dose, if you will, of cardioversion for a child is 0.5 to 1 joule per kilo, and obviously we would do that in a sync mode. And if we're actually defibrillating a child, remember that your dose of defibrillation, dose if you will, is 2 joules, and then if we have to repeat it, we usually use 4 joules. And remember that those doses would obviously be different if you had a biphasic pediatric defibrillator, but those tend to be pretty few and far between, so everybody, for the most part, is still using regular dosing for peds in defibrillation. Okay, when we talk about common injuries in peds patients, remember that when we're talking about the abdomen, the rules for peds patients are the same as they are for adult patients. When we talk about hollow injuries, the big concern we have with hollow injuries is that if we rupture a hollow injury, if we rupture a hollow organ, whatever's inside is going to be spilled out. And the big problem is those kids tend to get peritonitis and infection. And when we talk about solid organs, the big thing with solid organs is that all of the abdominal solid organs are very vascular, so our big concern is bleeding, just like it is in adults. Remember, we already said that when kids have fractures of long bones, especially multiple fractures of long bones, that suggests a significant force, so we need to be very cognizant of the fact that they may have some fairly major trauma. And remember that when we talk about Waddell's triad, we said Waddell's triad is something that is an injury pattern that theoretically occurs when a child is hit by a car. And for whatever reason, they love to ask about Waddell's triad on certification exams. Remember, Waddell's triad is 3 mechanisms of injury that occur when somebody is struck by a car. The first mechanism of injury is what occurs when the car strikes the person. So, for example, the bumper strikes you in the legs and fractures your legs. That's injury number 1. Well, as you're struck, that tends to make you fall onto the hood of the car. When you're thrown onto the hood of the car, whatever surface was presenting to the car is going to be injured as well. So a lot of times, like in adults, or in peds patients, in theory, they tend to not turn away and just stay and kind of like get that whole deer in the headlight look. So the part of their body that's presenting to the car would be their chest. So with that second mechanism, as they hit the hood, we would expect to see chest injuries. Now, so the first mechanism was we got struck in the legs. The second mechanism is we were thrown over the hood of the car, which created the chest injuries. And finally, the third mechanism in Waddell's triad is injuries to the other side of the body when it is thrown backwards onto the ground, which typically means the head, especially in peds patients. So again, with Waddell's triad, we're looking at 3 mechanisms. The first mechanism is the car hitting you, the second mechanism is you hitting the car, and then the third mechanism is you hitting the ground. Now, when we talk about common injuries in peds patients, the big thing you need to know about, the number 1 cause of mortality in peds patients is actually, from an injury standpoint, is actually motor vehicle accidents. So anytime we're taking care of a kid who's been in an MVA, we want to have a high index of suspicion for significant trauma, especially if they were inadequately restrained. Okay, when we talk about non-accidental trauma, obviously here we're talking about things like abuse. The big things with abuse, remember, you always want to have an index of suspicion for abuse anytime the story doesn't make sense. For instance, when somebody brings in a child who's 3 months old and tells you that the child rolled off the bed, well, that doesn't make sense because 3-month-olds don't roll off beds. The other thing that you also want to be looking for is obviously that history of multiple injuries, especially if there's multiple instances where they don't make sense. Then we want to be thinking about things like non-accidental trauma. Remember that reporting is something that is required by law in every single state in the country. If you suspect that the child has been abused, then you have an obligation to report that suspected abuse. And usually most states say that that abuse has to be reported to Child Protective Services. Remember that telling the ED staff, for instance, if you're part of a transport team and when you get to the hospital, you tell the hospital staff, I think this kid has been abused, that doesn't meet the requirement. You, as the clinician, have a responsibility to report suspected child abuse yourself directly to Child Protective Services. And remember that in most states, not only is there civil legislation about this that says that if you fail to do that, you can be sued, there's also criminal legislation that says if you suspect child abuse and you fail to report it, then you are committing a crime. So remember, anytime you suspect child abuse, you not only need to report it to the staff that's taking the patient, but you also need to make that phone call yourself and report it to Child Protective Services. Now, when we talk about what's abused, probably the most commonly abused organ is the skin. We see that in the form of things like burns and cigarette burns and dipping injuries and stuff like that. But the most common system that's abused that causes death is actually the head. And we see that in the form of things like shaken baby syndrome and stuff like that. Other things that we want to look for multiple injuries in various stages of healing. We discussed that already. And the other thing is we want to consider sexual abuse if the child's got any kind of genitourinary injury, or if we see abnormal GU infections in a child who's not old enough to be at that age where they're having sex yet. Okay, now let's take a look at orthopedic injuries. There's several different orthopedic injuries that can occur, and we have all kinds of different types of fractures. And for most of us, this is probably something that we haven't looked at since we were in nursing school or EMT school. So just a quick review here of different types of fractures. The first type of fracture that we may have is something called a comminuted fracture. A comminuted fracture, a great example, that is the x-ray that you actually see right above me. Remember, this is where we have a significant blow, and that significant blow has caused the bone to break into multiple pieces. We all remember compound fractures because we deal with that a lot. We know a compound fracture is when the bone is broken and parts of it have actually pierced through the skin. Remember that anytime, the standard of care is anytime you have a fracture in an extremity and you have a puncture wound anywhere within that vicinity of that fracture, they assume that that's a compound fracture until proven otherwise. It's not uncommon for the bone to pop through the skin. And then with realignment, either when we get there or before we get there, that piece of bone may retract back in. So they're going to treat that as a compound fracture from an OR and from an orthopedic standpoint. When we talk about a compressed fracture, that's where the ends of the bone are forced against each other. So for instance, like if I fell down a flight of stairs, or if I, let's say I fell out a window would be a better example, and I landed on my feet, it's not uncommon for those bones in my lower extremities as they sustain that impact to actually end up with compression fractures. A displaced fracture is when the ends of the bones aren't aligned. So for example, if we've got a fracture that's been broken like this, but the ends of the bone aren't sticking in the same direction, then we would call that a displaced fracture. Remember, a green stick fracture is an incomplete fracture. So for example, if I've got a bone and it's only broken halfway, but the other half of it is still intact, we would call that a green stick fracture. Pathologic fractures are fractures that occur because of bone defects. So good examples of pathologic fractures are things like when women are very prone to getting hip fractures when they're postmenopausal because of deficiencies in calcium and because of the weakening of their bones that comes with osteoporosis. The place where we can see this a lot in peds patients is like in kids who have things like osteogenesis imperfecta, things like that. It may take just something really simple to cause a fracture, something that would normally never even harm a healthy bone can break a bone in somebody who's got that weakening like that. When we talk about a simple fracture is when we just have a straight across break and everything is still aligned, everything's still in perfect position. It's just a clean cut kind of break. And finally, when we talk about spiral fractures are caused by a twisting motion, so it's like there's a twisting fracture of the bone. And when we talk about spiral fractures in peds patients, especially in little kids, a lot of times we really tend to have a high index of suspicion for abuse. That's kind of one of the classic things that we look for when we're looking for abuse in children, is especially spiral fractures of the upper extremities because they've had their arms twisted or things like that. So certainly kids can get themselves into contortions where they can have a spiral fracture that's not abuse, but anytime we see a spiral fracture, we always want to make sure that the story really lines up with the injury. Okay, when we talk about seizures, remember that peds patients a lot of times have seizures for the exact same reasons that adults have seizures. So some common reasons why peds patients might have seizures might be things like hypoglycemia, hyperpyrexia, or febrile seizures. We may see it because of increases in ICP, and we may also see seizures in pediatric patients because of a low sodium or hyponatremia. Remember that seizures can be primary or secondary. Primary seizures are seizures that occur because of a deficit in the brain or some kind of localized irritable focus in the brain, whereas secondary seizures are seizures that are just symptoms of a bigger disease. So for example, when somebody has a seizure because they're hypoglycemic, that would be a secondary seizure. Remember that in peds patients, it's pretty rare for them to have the classic adult presentation of a seizure. When we think of adults, typically what we think of is that adults first have an aura, then they lose consciousness, and after they lose consciousness, they go into this tonic phase where they get really, really rigid. Then they move into a tonic-clonic phase where we have generalized movement, and then finally the last thing that happens is the patient has a postictal phase. In children, we typically don't see that. Instead, in children, what we typically see is something called subtle seizures. And the younger the kid is, the more less likely it is that we're going to see the classic adult presentation of a seizure. In little kids, a lot of times we see these subtle seizures, and remember, subtle seizures are things like the kid just kind of deviating their eyes off and going to a land where you're not at, or they may be things like lip smacking, they may stick their tongue in and out, they may bicycle their feet, but they don't typically have the full-on tonic-clonic kind of seizure. So again, subtle seizures are more common in children than tonic-clonic seizures, but the older the child gets, the more likely they are to have seizures that look more like what an adult seizure looks like. So let's just review again the breakdown of the different types of seizures. We just talked about subtle. Remember that when we talk about clonic seizure activity, what we're talking about is the movement, the extension and flexion that alternate. So we're talking about the whole actual kind of what we think of when we think of a seizure, lots and lots of movement. In contrast, when we talk about a tonic seizure, remember we said the tonic seizure was where we become really, really rigid. There's not a lot of alternation of movement. It's just a sustained rigidity. And finally, the last type of seizure that we can have is something called a myoclonic seizure, which is where we have multiple jerking motions, and they're usually just limited to the upper extremities. So those are some of our more common types of seizure activity. Okay, when we talk about thermoregulation in kids, remember that the big thing we want to do is we want to be very cognizant of the fact that we're watching their temperature. Remember that kids, because they have large surface area to volume, tend to get cold really, really easy, so we want to be really, really careful about watching their temperature diligently. And if you look at the guidelines put out by American Academy of Pediatrics, they say that when kids are in a transport environment, they should have their skin, they should have continuous temperature monitoring either with a skin probe or with some kind of soft rectal probe, and then additionally it should be backed up with measurement at least every 30 to 60 minutes by another method. So we should have some kind of continuous skin temperature monitoring and then some backup method that we're using transiently at least every half hour or hour. When we talk about the way that kids respond when they get cold, obviously the big thing that happens first is their neurologic status changes. And just like adults, when they very first get cold, they go through kind of a little hypermetabolic state where they become very, very irritable. We may see infants doing things like crying and things like that, children complaining, older children who have the ability to vocalize complaining that they're cold. But remember that kids, their hypermetabolic phase of hypothermia is very, very short because of the fact that they have very limited glycogen stores. So very quickly they transition into a hypometabolic state, which is where we see suppression of their level of consciousness and things like that. When we talk about perfusion status, we all know that the more cold kids are, the more they shunt blood away from their periphery, so we really want to be watching capillary refill and things like that. And then finally, when we talk about vital signs, again, it depends on whether they're in the hyper or the hypometabolic state of hypothermia. Initially, we expect everything to pick up in an effort to try and keep themselves warm, so heart rate goes up, respiratory rate goes up, blood pressure goes up, but very quickly that will be burned off as soon as they lose those glycogen stores that allow that to happen, and then they'll move into the hypo stage of hypothermia where they become, everything slows down, heart rate goes down, blood pressure goes down, so on and so forth. Okay, when we talk about fever in kids, remember that for every degree Celsius that the kid's temperature goes above 37 degrees, we should expect to see that their heart rate's going to go up by about 20 beats a minute, and their respiratory rate's going to go up by about 10 beats a minute. Remember that when we're using external cooling measures, that's absolutely an appropriate thing to do. We just want to make sure that they're not going to be damaging to the skin, and we want to make sure that we're not cooling the child so quickly that we actually make them start to shiver, because that would be counterproductive. They're just going to start to generate more heat. So we want to be judicious in cooling, and as a general rule, we want to cool kids fairly slowly. Remember that we don't typically use aspirin for fever control in kids. There's really only one disease where we typically use aspirin in children, and that's Kawasaki's disease. But for the most part, we tend to avoid aspirin in children because there's at least a theoretical risk of them getting Reye syndrome. So instead, we use Motrin and Tylenol. Remember that we can use Tylenol as soon as a baby is born. In general, we don't use Motrin until the child is at least 6 months old.
I'd come for you, no one but you. Yes, I'd come for you, but only if you told me to.